So today we're going to talk about, excuse me, so today we're going to talk about fibromyalgia and Hashimoto's thyroiditis. And I'm Martin Rutherford. I'm Dr. Rutherford, certified functional medicine practitioner, chiropractor.
Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractor.
And today we're talking about the connection between fibromyalgia and specifically Hashimoto's thyroiditis. Fibromyalgia was when Dr. Gates and I got together in here a little prior to that, our group of doctors was one of the first conditions that our group of doctors endeavored to tackle was fibromyalgia. There wasn't a lot of data on it at the time. It was still considered maybe a diagnosis of exclusion, as it still is in some areas today. In other words, if they couldn't find anything else, you had fibromyalgia. It was thought to be a muscle problem, and there was no testing for it, and on and on. So this seemed like an area that would lend itself to giving us the biggest opportunity to figure out what was going on with chronic pain. Over the years, there's been an explosion of data on it. Not all of it has gotten out into the field clinically or therapeutically, but we know there's neurological components of post-traumatic stress syndrome. We know there are neurological components of peripheral neuropathy. And we know that there are at least a handful, if not a ton, of different gut issues that can contribute to it. But one of the main consistent features of fibromyalgia is its connection with Hashimoto's thyroiditis. And it is a significant connection. For those of you who've watched this, you probably know I have fibromyalgia and I have Hashimoto's and I have the gut problem and I had the peripheral neuropathy and I had the stress component. But I can't hardly remember a patient that has come in here with confirmed fibromyalgia versus, I mean, relative to our vet testing procedures, who did not have Hashimoto's thyroiditis. And I mean, we've treated probably a couple thousand. So today we're going to talk about that. Dr. Gates is going to do the lion's share of the talking here because he's our research center. He's R&D for Power Health Rehab and Wellness. And so Hashimoto's thyroiditis. I know we have a lot online, but maybe quickly, what is it? And what's the history of its association with fibromyalgia?
Yeah, well, this whole process has been so exciting as I kind of reflect on it, to really go back to where we were in 2009. I mean, we were treading water, trying to figure out how to help fibromyalgia patients. Really, all we knew at that point was that there was a stress component. We knew that a lot of people had been exposed to high levels of stress, and the stress hormones were causing a person with fibromyalgia to have increased pain responses, is a good way to think of it, rather than me saying central sensitization. And that we were doing brain work, we were trying to activate certain parts of the sensory brain, and we were getting results. Now, fast forward, gosh, it's been almost 8 years, and the data is there in a striking fashion. So relative to what Dr. Rutherford said about Hashimoto's, many of you have this concept of, okay, I have fibromyalgia, I've been to my doctor, my thyroid has been checked time after time, and I've been told I'm normal. We hear this story probably 90% of the time.
3 times yesterday. And I only had 3 new patient consults yesterday.
And you were 3 for 3 on that.
I was 3 for 3.
And the thing is that you have to understand, when people are telling you, or a doctor or someone is telling you that your thyroid is normal, what they're usually saying is that their blood tests for the thyroid, specifically, usually it's a couple blood tests, and they're looking at hormones for the thyroid, are normal. We need to take it about 8 steps farther, literally, because with this association between the thyroid and fibromyalgia, the association is the immune system. So we need to look at immune cells attacking the thyroid, not just how your thyroid is producing hormones. And the vast majority of patients with fibromyalgia that come into this clinic who are told that their thyroid tests are normal have not had these immune cells run for their thyroid. The immune cells are the thyroid peroxidase antibody, write this down if you want to, thyroid peroxidase antibody, thyroglobulin antibody, and new research is even looking at the thyroid receptor antibody and its association with fibromyalgia patients. Now, it probably would be helpful if this is something that's interesting to you to go back and watch all of our other broadcasts on thyroid, because we explain it ad nauseum all the nuances regarding the thyroid, because many of you, when you're told that your thyroid is normal, it may be in the normal range in terms of the hormone quantities, but lots of times there's this gray area called subclinical hypothyroidism that's also important, that's being neglected for you. So maybe your tests are kind of borderline low or kind of borderline abnormal. And just, if you hear that at all, know it's significant. And if I were you, I would not give up on there being an association between your thyroid and your fibromyalgia until you've had all the tests run, and when they've been interpreted with a microscope, or a magnifying glass would be a better term. And then also, you have to understand that there's debate in the scientific world as to what constitutes a high value of immune cells to the thyroid. This is another detail. And for example, we use LabCorp. And when we run the immune cells of the thyroid, specifically the thyroid peroxidase antibody, they say anything over 34 is too high. However, the Mayo Clinic says anything over 9 is too high. Both of our local hospitals, one says 9, one says 8.9. So this is really, really important, because there's a lot of people, there are a lot of you who are in this gray area. Maybe you're at a 10, maybe you're at a 15. And if you get a test through LabCorp, you're going to think that you're normal. But if you get a test by one of these other labs, it's going to say you're abnormal and you have Hashimoto's. So that's very, very important. Anything you wanted to add to that before I kind of move on?
No, I mean, you're gonna talk about how Hashimoto's creates immune inflammation and things of that nature. I mean, the thing I would add only would be, if you have fibromyalgia, I would just assume you have Hashimoto's from what we have seen. And Dr. Gates is correct in that we have been saying forever that over 9 in the lab range is Hashimoto's. So all these people who have still lab ranges between 0 and 32 and 0 and 64 and 0 and whatever, there's still some labs out there doing that. You're being told you don't have something that you have. And that's confusing. And I did have 3 of these yesterday. And I only had 3 consults yesterday. I do the intakes to try to evaluate, and it is confusing to people, and it can stop them from pursuing things. Because I look at Hashimoto's, I look at the thyroid as secondary to the immune attack. I'll often say to people, it's a maybe you want to go over the fact that it's kind of like a what's the word I'm looking for?
Like a gradient.
Like a gradient. So you start at the beginning and you just get certain symptoms, and you get a hypothyroid, and you get hypothyroid symptoms, and then you go on and on and on and on. And as more cells get attacked, or you start getting inflammation, then you start getting more hypo and hyper symptoms. And they're telling you that your lab tests are normal, or they're telling you that you're hypothyroid. It's because at different parts along the way, you can exhibit different symptoms. And so it's confusing, as Dr. Gates said, and it is something that I find the most challenging in getting through with the patient that first day. When one of the ladies yesterday, she came in, she had all of her thyroid tests. I said, well, they're normal, and she had 18 out of 20 symptoms of Hashimoto's, and so this is a confusing area, and for all the reasons that Dr. Gates said, but it's a key to your condition. And if you find someone who understands what the components of fibromyalgia are, it's going to be a big key to you getting well and improving and being able to function normally.
Yeah, absolutely. I would say, watching our broadcasts on Hashimoto's, it's like the thin Hashimoto's patient or something like that. You can get all this on powerhealthtalk.com. So you just go to the search tab, search thin Hashimoto's patient. In there, we really talked about some really cool new literature, because they're showing, for example, you have to consider there's 2 separate problems with a thyroid issue. There's the immune component and there's a hormonal component. The vast majority of the literature is weighing that the immune component is almost more important than the hormonal component. Just a little case example, I have one patient recently who had a thyroid stimulating hormone near 200. Now, just so you know, anything over 3.7 is really a problem. Anything over 4.5 is medically an issue. Anything over 8, most doctors are going to treat you. And this person had a TSH close to 200 and overall felt pretty good because we're controlling the immune cell response over here. That's an isolated example, but the literature is showing that these immune cells to the thyroid, they not only attack your thyroid, they actually go into your brain and they attack a variety of neurological tissues in the brain. And so these research studies on fibromyalgia, they're looking just at the immune cells to the thyroid and seeing that in one study I attached to today's broadcast that you can get on powerhealthtalk.com, they took a group of Hashimoto's patients, not even saying, okay, this is just a cluster of Hashimoto's patients. 62% of them had fibromyalgia, which is a huge, huge, huge association. Also, as Dr. Rutherford is saying, the degree of, for quantifying what a Hashimoto's patient is also important too, because these were probably, I haven't looked at, I don't remember, excuse me, the exact
0 to 34.
Yeah, I don't know what laboratory range they were using, but I presume it was higher than 9, but I can double check that for you, and the article is online so you can access that too.
Which would have made the percentage even higher if that's
right.
the case.
So there's and this first came out massively in 2014. It was Clinical Rheumatology, and they were talking about this association between Hashimoto's and fibromyalgia. And I really had a fun time this morning looking at the research because that association has just grown and grown and grown. And they're seeing that Hashimoto's overlaps with a lot of other rheumatological diagnoses too. It overlaps with rheumatoid arthritis, it overlaps with lupus, it overlaps with scleroderma. And the thought is that the thyroid is kind of like the canary in the coal mine. It's the first organ in our body that is going to start attracting immune cells to it when there's inflammation.
It clearly is. I mean, I don't know what the research says, but I mean, I pretty much tell people once you get an autoimmune problem, the next thing is getting hit is your thyroid. If it wasn't already the first thing that got hit before you became the other one.
Completely, because the thyroid actually does exactly that. When there's inflammation in the body, it actually attracts immune cells to it. Yeah. And then you start making immune cells to your thyroid, then they start going into your brain, affecting your frontal lobes. It affects blood flow, attacks potentially your cerebellum. So now patients start to experience maybe depression, maybe brain fog, maybe balance issues, dizziness, vertigo. And you overlap that now with the findings on small fiber peripheral neuropathy that we talked about last week, which is where your pain nerves start to die and degenerate. That's seen in a large proportion of fibromyalgia patients. Or your pain receptors are dysfunctioning, seen in 76% of fibromyalgia patients. So now you take all that data and you have somebody who has chronic unrelenting pain that they can't find a reason for because it's a neurological disorder and people have not been looking for the right cause of it because we just didn't know. But we're trying to get this information out there because there's still an incredible amount of misinformation and lack of understanding on fibro. That was a little aside. Okay, keep going. So now we have somebody who's in chronic pain because they have small fiber peripheral neuropathy or pain nerve receptor dysfunction. And then they have Hashimoto's thyroiditis and their immune system is attacking their thyroid and their thyroid tests are normal, but the immune system is still attacking their thyroid and all those immune cells are going into the brain, causing brain fog, depression, dizziness. And then because the pain is so severe, maybe they have a stress component because of previous childhood trauma or other massive stressors, they start not sleeping well. And because of that sleep being disturbed, they stop making the chemicals in the brainstem that shut off pain. And now you have this collective syndrome called fibromyalgia. We just outlined, these are the causes of it. This is what's wrong with so many of you. And you may not have all 3 or 4 of those. Maybe you have 1 of those. Maybe you have 2 of those that are really demonstrative. And then you add in the gut, which we're going to talk about next
celiac.
week.
Celiac. One of the first connections was maybe between Hashimoto's and celiac.
Yeah, and now we're finding that gluten sensitivity
and celiac is what, 1% of the population, but it's like 30 or 40 or 50% of the Hashimoto's patients or something like that.
There's upwards of 50% of Hashimoto's patients have gluten problems. So now you tie that data in and what the gluten response is doing, and now they're seeing, I attached an article where with celiac, you need to go back and watch our broadcast. Celiac, as Dr. Rutherford said, is 1% of the population. But now we have non-celiac gluten sensitivity. So these are people who eat gluten and they don't feel well. Usually it's a neurological manifestation. And they're finding that there's one little piece of the gluten molecule, the gliadin molecule called the 33-mer, that when the immune system starts attacking it, it actually makes immune cells that attack a certain type of glutamate receptor. It's a receptor for a neurochemical in your spinal cord and your brain. And that can throw off pain signaling. It can be associated with restless leg syndrome, fibromyalgia, on and on and on. So now we have this really cool kind of diagram of all these little bubbles that are potentially wrong with the fibromyalgia patient, Hashimoto's being one of the main ones. And there's a big Hashimoto's association between the gut, as Dr. Rutherford is saying. And that's why so many of you, and fibro is like 2 to 7% of the population, are out there suffering, not having answers, misunderstood.
Doctors chasing all those different ones, pernicious anemia, Meniere's disease, associated with polycystic ovarian syndrome.
Oh yeah, it goes on.
I mean, it's enormous to understand if you're going to evaluate properly. If you're going to do an astute diagnosis on a fibromyalgia patient, you have to know all of the nuances of Hashimoto's thyroiditis and its connections to even begin to hope to be able to dampen the immune response, stop the downward progress, and reverse it.
Yeah.
I mean, and we probably don't know everything. I read an article last week, I'm sure he's already read it, that was saying they pretty much think all autoimmunity is coming from the gut. And I read that article when I was researching a little bit on Hashimoto's, and that sent me to that. And so the point being, there's more and more data coming on these things, but it's really all relative to either like the immune attack that they just keep finding is attacking more and more organs in different people, but it still comes down to the immune inflammation. But the thyroid is the canary in the coal mine for sure.
And the data at this point is staggering, frankly. Those who are looking at the data. And a major reason or impetus why we do these broadcasts is because, like, I read an article this morning out of I think it was the Journal of American Family Physician or something like that. And they were talking about fibromyalgia. And I'm sorry, but the stuff they were saying is 20 years old. You need to exercise. We need to look at, using serotonin-specific reuptake inhibitors like Prozac or Cymbalta. That's all well and good, but there's so much new data now for a fibromyalgia patient that's exciting, that can help people. We need to get this out there because this is what's going to really lead to a solution. I'm sorry, you taking a walk every day. Most of you can't even walk. You're told to exercise and you can't exercise. We hear it all day long, but you're told you just need to pull up your bootstraps, exercise, go get counseling, take your Prozac, take your Cymbalta, and we'll see you later. Well, that's not an adequate solution based on the current data. I'm sorry, but it's not.
Yeah.
So
that covers it, I think. I mean, we can go on with this for hours, but
and we will.
We don't want to.
So
we've been told not to.
So we're trying to conglomerate all this information into one broadcast. So we've been filming that. We're going to continue filming this week and maybe have it done hopefully soon. It's called Fibromyalgia, Cutting Through the BS. So if that's of interest to you, I think you can find it on Facebook. But anyways, you can access the research articles on powerhealthtalk.com. If you have a broadcast that you want us to talk about, send us a message. We appreciate you watching, and we may see you next week.